It's time to focus on seniors with Helping Seniors TV. The television show designed to make you aware of senior issues and needs, as well as to acquaint you with the resources available to help you age in place and with dignity. Now, here's your host, Joe Steckler.
I'm Joe Steckler, and welcome to Helping Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is understanding hospice care. Joining me is Dr. James Brodnan, Hospice Medical Director, Wuesthoff Hospice. Welcome, Dr. Brodnan.
Thank you.
Glad to have you here.
Thank you. I'm glad to be here.
Well, we did a recent radio show, and as a result of that radio show, it just sort of strengthened my belief that more of our viewers need to understand not only what hospice is and what it does, but it's why it's so important for them to know about it. Many people don't know about hospice. Even in this day and age, they still are trying to find that resource out. So help our viewers understand the origins of hospice, how it came about, and what you do today, and why it's important to you as a medical director.
Okay. Hospice, I think, started in England in the 60s, mostly as a result of need for end-of-life care for people with cancer. And then it came to the United States about 10 years later, and it's evolved tremendously since that time, to the point now that about only 40% of our patients are actually cancer patients that are in hospice, and there's numerous other diagnoses now that we care for the patients at end of life, such as congestive heart failure, lung diseases like COPD, renal failure, kidney failure, and also the biggest one is dementia.
When I was the director of the Alzheimer's program here many years ago, that's where I had my first experiences with hospice then, because it was so hard for the family, and I saw for myself firsthand the value of the hospice team itself as it came in to help the families, Dr. Brodnan.
Especially with dementia, which is a kind of a long, protracted illness. The caregivers have a very difficult time caring for their loved ones over that long period of time, and there's lots of things we can do to help the caregivers, the patients, over the time that they decline from their dementia.
You said there's a lot of things you can do. What are some of those things that the hospice team does?
Well, once the patient enrolls in hospice, we have a large team which physicians, nurses, social workers, chaplains, volunteers, dietary people, wound experts, psychologists that all help in whatever the needs of the patient and the family are. The patients are seen regularly each week by a nurse, by an aide, and then whatever other these assets that we have that are particular to that patient are at their ability to use at all times.
Okay. In doing the radio show, you brought to my attention some misconceptions I had about hospice, and as many shows as I've done about hospice over the last 15 years, I didn't believe I could have my eyes opened that many times differently, and you certainly did it. Because there's such a thing. We use the words aggressive care and curative care. Curative was what you said, right?
Curative and then palliative. Mm-hmm.
Okay. But how do you make the decision, or how do families know when to really stop the aggressive treatment and then rely on the palliative or the hospice care?
That's a good question, and that's a common question that families wrestle with, and that's where we come into play quite a bit. They're used to having care by physicians that's curative. We're always trying to solve their problems, cure their problems, and in all these diagnoses that we talked about, at some point that patient reaches a point where either they realize, the family realizes that whatever their diagnosis and whatever their problem is can't be cured. And then that's where we go for palliation, which is basically we're doing things to make them more comfortable. If they have pain from their cancer, we're giving them pain medications. If they're having spiritual issues, we get the chaplain involved for that. If they're having shortness of breath issues, we address that. So it becomes doing everything to cure the problem, to realizing that we can't cure the problem anymore, but there's many things we can do to help them in their days as they go through their journey.
Yeah, but many people are laymen like me, and I'm sure a lot of you viewers, when you think about hospice care, they think about the person dying almost right away. And they say, well, why does the primary care doctor keep doing these things which seem to be counterproductive to just letting the patient die? And you very, very nicely explained that on the radio show, saying that while a person appears to be dying, there are other things that are important that sort of either add another obstacle in the dying process if the curative doctor doesn't take care of it. Can you explain that?
Sure. There's lots of things that patients go through in the end of life that we can help them with. For instance, sometimes the dying patient may want to make amends to a family member that they've been estranged with before, or they spiritually want to get back with the church, or they want to have closure, or they want to talk about their journey and their legacy, about their life. And so we help them with that in any way we can. And that involves, as we talked about, all sorts of nurses or spiritual people or psychologists. And I think that's where at the end of life we make a big difference, not just treating their pain, but helping their spiritual and their emotional issues as well.
I know that I in reading the Wuesthoff paperwork on your hospice care, it came about the vision-like experiences that often patients have, and there are so many theories and books about life after death. We don't really know what that patient is seeing as they approach the end. And while they're being medicated, they have drugs in them, but it seems like they still have a mind. And far be it from me or for anybody to say they don't see something, and I'm not trying to, what I'm saying is that it's the way hospice team enables that person to accept what is happening. Does that make sense?
We do. Not only do we have the patient help them to accept what's happening, but oftentimes just as important is for the family to accept what's going on. And that's oftentimes one of our biggest hurdles is to get the family to realize that the patient understands that they're dying, that they're comfortable with the dying, and that the family will become comfortable with it too.
Yeah. I spoke to a recent group of caregivers, and the lady sitting across from me was a caregiver that had been taking care of my wife's cousin that the Wuesthoff hospice team was providing the service for the end of life. And she commented on the courage and the way my wife's cousin was handling her death. And I think a lot of it had to do with the Wuesthoff team that was there with medication, understanding, the nurse saying, no, Mrs. So-and-so, you don't need to adjust those medications. That's our responsibility. And I have found over the years, Dr. John, that one of the biggest problems for people that are in hospice or the families of people in hospice is to let the hospice team manage the medications, do what needs to be done. Do you encounter that kind?
Absolutely, and actually that's a service that we provide that's very helpful, because frequently as patients are declining and they're requiring increasing amounts of, say, pain medication, families are oftentimes reluctant to be the sole provider of that medication because they feel like they're the ones that are maybe making this happen. And so when we're involved and our nurses help with that, then the families are able to kind of be a family member and not really be the person that's participating in giving the medications. And maybe they get a feeling that maybe they're participating in this person's decline, which they're obviously not.
I also know that the hospice nurse can bring and through you as the medical director, can bring medications and pain management techniques to bear as death approaches that I'm not sure that the family members could do.
I think that's absolutely true. And we also provide a level of, especially in pain management, that some of the primary care physicians are just a little uncomfortable doing, at least in the amounts and the doses that are oftentimes necessary in folks when they're in the end of life. And we're comfortable using multiple drugs and higher doses that really make a difference for the patient.
It's necessary sometimes.
Absolutely necessary.
I know the person I'm thinking about recently died under in Wuesthoff Hospice. She actually did not feel any pain, but I think a lot of it had to do with the medications that you were giving her. But she, really up until the very end, she still had a pretty good idea of what was happening.
That's our goal. Our goal is to try and walk that very narrow path that we can control their pain and keep them as lucid as possible. Sometimes near the end that's not possible, but that's our goal.
Okay. Earlier on the show, I asked you something, and I may not have stated it a way to get you to get the answer that I wanted, or I think it was. It's in a case of where we have the hospice team caring for the person, and the primary care physician is still involved, and to an outsider, it might appear that one medical element is still doing aggressive treatment while the other is trying to provide a peaceful end. And you explained it to me, because you made me understand, or helped me understand, that there are other things that have to still be done medically in order for the whole system to work.
Sure. For instance, a patient may have cancer and we're helping them work with them with hospice to treat their cancer and to help their pain from their cancer. But that same patient may also have diabetes, and they may also have hypertension, and those things need to be addressed. And frequently the primary care physician will be involved to help take care of those things. And so we work in conjunction with the primary care physicians, and we do as much or as little of that as they would like. If they want to manage everything and we help with the main hospice diagnosis, that's great. If they want us to do everything, we're glad to do that as well.
Hospice is paid for by Medicare. Most of the people you serve probably are 65 or older.
Most are, yes.
Largely. But how does one apply for hospice? Does the primary care physician always refer hospice to them, or them to hospice? How does that work?
Typically, a physician will make the referral. Sometimes it's the primary care physician. Usually it's the primary care physician. Sometimes it might be a specialist. If the patient has cancer and it's an oncologist and they've reached the point where there's no treatment available, it may be a oncologist that does it. But anyone can do it. And then the patient or their representative or their family has to sign the forms opting to go into hospice care.
Okay. Let's say that a person goes into hospice care. Who is the first person from the hospice team that will see the potential client?
Typically, the hospice admission nurse will come out, assess the situation, talk to the patient, talk to the family, make sure that everyone is interested and wants to sign up with hospice, understands what hospice means, which is that you're going to pursue a less aggressive palliative form of therapy and not aggressive curative care anymore. And then once the papers are signed and the admission nurse is involved, then a nurse from the field or from the hospice house will see them, I will see them, and then the whole process of how often they're seen by aides and whatever else they need steps into play.
Okay. It recently was brought to my attention that, and it forms sort of an opinion on my part, that hospice is not equal in all parts of our United States. Brevard County is very blessed to have 4 hospice organizations, but I think we have 3 hospice houses. I think that's right. But I know, and I made a promise to myself that I've got to get over and see the Wuesthoff Hospice. I know where it is, but I haven't been inside. But having said that, while you and I are talking about the advantages of home care and facility care for hospice, they're going to put something on the background that's going to show the entrance to your hospice house, and there'll be a little bit about that, and we'll work that into the tape. But knowing that's happening, how do people make a decision, Dr. John, as to whether the care is given in the home or in the facility?
Okay, well, most of the choice is the patient and the families, and that most people would like to be in their home in their end of life if they can. And that's what we prefer, and that's what we usually do, and that's where most of the patients are. They're either in their homes, or they might be in an ALF, or they might be in a nursing home under our care. Patients that have unique or difficult symptoms that cannot be treated at home or in the nursing home then would qualify to be in the hospice house, which is basically an inpatient facility. If somebody had cancer that couldn't have their pain controlled at home and they needed a specialized intravenous medication or something, they would be at the hospice house for that. And so it's more of it's an inpatient facility, if you will, and a very small percentage of our overall number of patients are in the hospice house, and it's for those specific severe problems, and everyone else is cared for in the environment they choose.
Do you find that, say, people in a community such as we live in Brevard County, is there a pretty good understanding of the availability of hospice, what hospice can do, or do we still need to do a better job of awareness? I
think we can always do a better job. I think the awareness, I think, is better. But we have these discussions when we meet with families in the hospital and under dire circumstances or in other situations. There's still a lack of understanding. It requires a lot of discussion, education and re-education, not only with the families and the patients, but also with people in the hospitals and in the community.
I echo what you're saying because having come from a very small community myself, and talk to members of my family right now that are going to have to place somebody in hospice care. They don't have the plethora of facilities and capability that we have here in Brevard County. And we think of Brevard County as one entity, but it's really a conglomeration of cities.
Sure.
But do you think we have an adequate hospice capability? Can you care for all the people that request hospice, or is there a problem anywhere along that line?
No, I think the 4 hospices in the county all do a really good job. I think they all now have their own hospice houses, so the totality of care from being taken care of at home versus an inpatient setting is there for as many patients as we can handle, which I think we can handle.
Let's say a person makes a decision and they want to have home care. And there are a lot of things they're going to have to change in that house. And you described some of those on a radio show. Tell our viewers what when the hospice team descends on the house, what can happen and how can change? What do you do to change it to make it fit the patient?
Yeah, well, one of the things that I do as part of my job is I make home visits regularly, and it's amazing to me what families do, what patients go through to take care of their loved ones. Knock down walls, change the house, move in a bed, stop working, just to take care of their loved ones, and it's absolutely amazing, and I never would have fathomed that it was the strength as it is that I've seen. But once somebody enrolls in hospice and they want to stay at home, nurses arrive, social workers arrive, chaplains arrive, and the need of the patient is adjusted according to what they need. If they need a nurse 3 times a week, 3 times a week. If they need an aide to bathe them 5 times a week, that's what we do. If they need me to come see them for an emergency, I do that. So it's adapted to each person's needs as we go along. To add to that, some patients, as we talked about, need inpatient care. They need specialized something that needs to be done at the hospice house. We can also provide that same care in the home if they prefer that by having a nurse in the home all the time. It's called continuous care, and it's done for short periods of time.
But as death approaches, you have nurses around the clock with the family.
If they need be, absolutely.
And the Medicare pays for the medication, pays for the drugs, pays for the care, pays for everything.
Medicare Part A pays for everything that the patients need that's associated with their hospice diagnosis.
Okay. Now I want to talk about something that we didn't discuss on the radio show. And it's something that most people would not go on television and talk about. I can remember a situation, many situations, where I've watched the hospice people in a home, and I've watched some very difficult situations where they moved beds in the living rooms and they moved all the furniture out. And I've watched wives caring for dying husbands, assisted by the hospice team, where it appeared to me, in what it could have been an extremely emotional setting, that the hospice team provided the support to the wife where she could put her hands on her husband's head and hold him while he died. We don't talk about things like that, John. We really don't. But that's an element that hospice brings to the care situation. Can you talk about that a little bit?
Sure. I mean, that's obviously important for the loved one that's dying. It's really important for the family member that's caring for that patient. We tend to forget sometimes that caregiver, especially in some of these diagnoses where it's a long process, such a dementia patient, that caregiver may have been caring for that patient for 3, 4, 5 years, almost continuously. And those caregivers are at risk after their loved one dies for grief issues and major medical problems. And so by doing those sorts of things, by providing that social and spiritual support, we're making a big difference not only for that patient but also for their family members, and not only that day but for months and years to come.
But I think there's something that even you as a medical director don't realize how a potential client of your service feels. And it's the fact that the hospice presence somehow brings an element of confidence to the person that is watching their loved one die. I have seen it. I know what I'm talking about. And I think that's a part that our viewers, that you don't understand unless you've seen a death or unless you've seen a hospice team at work. You can't appreciate the peacefulness and the camaraderie that is developed through that team approach that you're talking about. And that's what I think is so important, that I could talk a long time about it, because I think that's extremely important, John.
It is, and that's the nice thing about being a part of a hospice team. I'm a pulmonologist by trade. I take care of patients in the ICU for 30 years.
I know.
Yeah. And when we take care of patients in the ICU, the doctor's vision is extremely important. In hospice, it's different. The nurse's input and the social worker's input and the spiritual side of it and the medical side, all important, but equal, or even my role is even less than theirs. Theirs is really more important. And that's the nice thing about the team effort, is that everybody participates and everybody feels like they're part of it, and everybody really is part of it, some even more than the physician by a lot.
Imagine me as a captain in the United States Navy. I had commanded the Navy's retirement home, and we had what we called a multidisciplinary team, and we had a round table in this conference room, and I had my pharmacist, I had one of my medical officers, I had a chief nursing, I had a social worker, I had 3 or 4 other people. But every week we met to discuss the people that were in the hospital or the assisted living facility, and we discussed the capability and ability to move the person from different element of care. as a submarine officer, I'm in charge of all that stuff. I found out what hospital accreditation was. I found out what dying was. I remember walking into a room and a man turned around to me and he had no throat. Nothing. I wasn't prepared for that. But thank the good Lord, I was able to handle it. But that taught me something that I think that makes me enjoy doing the type of show that you and I are doing, because I think the viewer is entitled to know more about the peace and comfort that hospice can bring and the ultimate demise of a person. As a medical doctor, what else would you add to what we're talking about, Dr. John?
Well, one thing that you touched a little bit on with the team effort is that we are charged by Medicare for taking care of these patients. We are obligated to meet about these patients and talk about each one of them, their totality of their care every 15 days. So we meet and we have social workers and the whole team and all the people that we've talked about, and each patient is talked about every 15 days in terms of their care. What do they need now? What do they need differently? Do they need something new? And so their care is always being overseen by me and all these other disciplines, so that they get the total care from an emotional standpoint, spiritual as well as their physical needs.
And I think another thing that, as we close the show, one of the important equations in a hospice team is their ability to bring the element of peaceful death to the patient, which it greatly assists the family as they watch a person die. I think that's so important. And I don't know any other organization that can help that dying process like a hospice team can. Is there?
No, I don't think so. And to that, the employees that we have, it takes a special person to do this. And the people that we have that work for us are those kind of people that are willing to take the time and do whatever it takes to make sure that the patient and their family is as comfortable as they can possibly be during those times. And
just to emphasize what you're saying is that I watched on a sort of an emergency note, I watched a male nurse from your Wuesthoff hospice team come to a home and easily settle a medication problem. And I saw, it just reinforced, John, what I think hospice could do.
Thank you.
You're quite welcome. It's been my pleasure to have you here, and I enjoyed doing both the radio and the TV shows, and we'll do another one. But I want to thank you, viewer, for watching today's episode of Helping Seniors. If you have a question or a comment, please call us at 321-473-7770. And for more information on senior care and resources, visit our website at helpingseniors.brevard.org. Be sure to listen to Helping Seniors on radio station AM 1300 every Thursday afternoon at 1 p.m. And look for our Helping Seniors newsletter in the center section of Seniors Magazine every month, and also Hometown News. I'm Joe Steckler, and I thank you for joining us today for Helping Seniors.